Welcome to the 17th webinar in the MGHS Institute for Innovation in Palliative Care Interprofessional Webinar Series. My name is Pauline Lesage and I am one of the physician educator at the MGHS Institute for Innovation in Palliative Care. Today, the topic will be assessment and management of nausea and constipation in advanced illness. As you can see, this agenda is a little bit heavy, so we may take a little bit more time than usually, and especially that I thought that it was important and maybe that we can learn something from it to talk about bowel obstruction, which is somewhat related to nausea and vomiting. So without any more fuss, let's start about the topic of today. Nausea, even though the title was nausea, as you know, nausea is most of the time associated with vomiting. I'll look at the literature, and there's very, very limited data about that, but most of what I could find was saying that approximately most of the time, more than 70% of the case, nausea is associated with vomiting. It can happen by itself, though. Nausea can happen by itself, and also vomiting can occur without nausea, but most of the time they are linked. The treatment of either or will be more similar, therefore it is interesting to treat them together. Definition of nausea, I think we all know very well that it's kind of this feeling queasy, sick in the stomach, something is going to happen. Vomiting will be, we all know that, rapid gastric content expulsion. And the retching, though, and this is a term that we use as well, retching is a little bit pre-vomiting, shall we say. It's kind of the active contraction of abdominal muscle. We have the sense that something is going to come, but not coming out. So retching is that. Nausea and vomiting, the same pattern. We can follow a little bit knowing how frequent that is, the etiology, pathophysiology, assessment, and management. Prevalence, as you know, all those symptoms that we are dealing with were mostly studied in the cancer population. We are starting, though, to have more information in other long-term disease, chronic illnesses, and this is what I try to illustrate here, that in advanced cancer we know very well that especially the closer to the terminal phase we are, the most likely you are going to find some nausea and vomiting. Overall, it can be only in 6%, but the more advanced you are, it can be up to 70% in cancer patients, especially, as you know, ovarian cancer and colorectal cancer. For other illnesses, it's interesting to see that patients hospitalized with serious illness, up to 7% will have some nausea, vomiting. AIDS patients, highly prevalent, 43%. Renal failure, it's associated with the disease, especially in end stage, in 30% of the case. Heart failure, 17%, and cancer patient, as we mentioned before. Oftentimes, nausea and vomiting is associated with other symptoms. And maybe this is why it did not receive enough time. We don't spend enough time talking about those. We privilege oftentimes pain, dyspnea, but those topics are sometimes relegated on the second level because they seems to be occurring in a mix of a lot of other symptoms as well. Etiology of vomiting, and as we mentioned in previous symptom discussion, it is important to know the etiology. If you know what you are dealing with, you can probably interfere and find the proper anti-emetic medication. So etiology and assessment is one of the most important things that you can do with the symptom. If somebody is calling you and said, patient has nausea, what could I give for this patient? Answer, nothing, I don't know. Tell me more. So tell me more will be in the assessment part of in further slides. So it can be related to the disease, any hypomotility, obstruction, constipation, CNS disease. It can be related to the treatment, especially we're talking about cancer population, related to chemo, radiotherapy, surgery. Can be drug-induced. It can be also related to all those metabolic disorders that are so frequent, especially in cancer population, but also in some chronic illnesses like hyponatremia, hypercalcemia, hepatic failure, so on and so forth. The last category, which I put the last because less commonly we are going to find that, and it's usually a diagnosis of exclusion. It can be related to psychological factor like anxiety or some other problems. Usually, this is what we call the anticipatory nausea and vomiting. That is oftentimes related with patients receiving chemotherapy. Just in anticipation of receiving the chemo, they are starting to be nausea and vomiting. It's important to have that differential diagnosis because the treatment of the nausea related to psychological factors is different. Even though it's a simple symptom and seems to be, you intake something and then you vomit something, it seems that the pathophysiology is not that simple. There's many mechanisms involved into the physiology of the vomiting, and it can be quite complex. Multiple centers are involved, as we can see. The cortical, the cerebral cortex, the vomiting center, the chemoreceptor zone, the CTZ, what we call, limbic system, effector organs, vestibular, and abdominal organs. And all of those are linked through nerves, as well as a lot of chemoreceptors that are involved in all of this process, which make it very complex. The importance of this schematic representation is to, as you can see, we see where the different stimuli will play a role. And therefore, when we are going to choose a drug, an antiemetic, we will be able to choose maybe a drug that is more specific to act on a specific center, and therefore give you probably a better results. Example, if you have gastric distension, gastric irritation, hepatitis, anything that is stretch capsule in the GI tract, then we know that the abdominal organ will be involved. Through the vagus nerve, there will be a transmission to the vomiting center, cerebral cortex, of course, and so we know that we will need medication that probably will act on the vagus nerve. So the same with position or motion, then the vestibular nuclei being touched. So we will probably privilege, if we have a patient who has example nausea secondary to movement, we'll probably have interest of having a drug who will play a role on the vestibular. The assessment in any symptom is really the cornerstone. There's no point of starting managing a symptom, whatever it is, without having a good sense of what we are dealing with. So as for pain, the same is true for nausea and vomiting. We need to assess the different characteristics, the pattern, the frequency, the triggers, intensity, distribution, the accompanying factor, and so on and so forth. The headache example we know very well. Just to give you an example, nausea, vomiting, accompanied by headache, we have a sense that it's probably central, that probably patient is having a central mass, a mass effect, and then therefore we would choose some antiemetic that will deal with that causation. Review the medication list. It's very important. It's so usual that medication can cause that, and we don't realize that we have many patients on antibiotics, example, in advanced disease, and a lot of them cause some nausea. And then, of course, knowing that, the treatment management will be simple. Just withdraw your antibiotics, change it, or DC it. So again, the assessment involves assessing the diet, the electrolyte disturbances being a cause of so many nausea and vomiting, especially in cancer population, and also renal disease, advanced renal and liver disease. I have a good history of recent chemo, radiation, and a physical exam. This is essential to examine your patient before throwing an antiemetic or starting dealing with the management of this symptom. Why? Because you may deal with bowel obstruction, and then it's very important because then you will adjust the treatment accordingly. So it's important to have a sense of the abdomen, of listening to the bowel sounds, and examine your patient appropriately. X-ray and labs can be useful in the cases that we have time to, and especially that we want to treat. If it is end stage and patients has a few days, maybe we don't need all of that, we'll treat symptomatically. But if there's any chance that we will intervene differently, if we find something at the X-ray, on the X-ray or in the labs, we should do them. Now the management, like any management of symptoms, there's always kind of two different approaches. The one is the general approach, do things to minimize, to avoid to have the symptom, and the other one will be a pharmacological approach. In the general approach, what we mean is that try to improve the environment when the patient is. You know, if you have a lot of movement around, if you have, if it's hot, humid, sticky, and, you know, especially if you have dealing with a patient who is already sick, you may have a little bit more nausea, vomiting, or even the others can, as you know, especially with patients with liver cancer, it can increase the nausea and vomiting. So knowing that, we can influence that. It's easy to do. Avoid rapid movement. If you have a patient that, by the question, do you have vomiting when you do especially a movement going from the bed to the chair or something like that, do you notice that? And the answer, yes. We have a good clue of what medication we will be able to give them. And let me give you a story, very interesting story. Many years ago, the palliative care team was called in consultation. A patient who was already seen by a GI specialist to manage the nausea and vomiting. A patient was having a cancer. It was a GI cancer, and we could not find out. He was already tried multiple of the medication that's on the market, and despite that, was still not really comfortable. We just asked one question because everything was already done, except probably one that was not asked, or we could not find out. Do you have any nausea or vomiting when you move? And the answer was yes. I noticed that it seems to be more frequent in those moments. And then we started medication for that was related to the movement-induced nausea and vomiting, and that was miraculous. Patient was so happy, and then of course our reputation went just up a level or multiple level. In this case, hydrate the patient. A patient who is totally dehydrated, of course, can have just a bad feeling, a queasy feeling. So some hydration, of course, if it's indicated. Progressive alimentation, dosing, it's important. Good mouth care. How oftentimes we make rounds, patients have filthy mouth. No wonder why they don't feel well. So again, this is a simple measure that we can do, and all the contributory factors that we can find should be dealing with before thinking of adding any medication whatsoever. The pharmacological approach, again, there's some generalization before switching to or thinking about a precise medication. If you already, when you start and you have a patient who is telling you that he has nausea most of the time, you will have to think about having medication that will be around the clock and not just occasionally. You have also to consider some treatment, so preventive treatment for nausea, vomiting, especially when you send a patient home, you know, and you put him on opioids or some other medication that may induce some nausea. You don't want the patient to call or come back in the middle of the night in the emergency room and say, I have nausea or vomiting. Be preventive, maybe just give a few doses of antiemetic that may help. Don't forget that if we have a patient who have nausea and especially vomiting, associated with vomiting, if you give medication orally and the patient happened to vomit after he took the pills, less than half an hour after that, the medication will be inactive, obviously. You vomited the medication and therefore you have no drug. So consider some alternative to the oral medication. And combine drugs that may be needed in intractable vomiting. Oftentimes, and we will see the same phenomenon in constipation, we need one or two different type of medication in order to control especially severe nausea and vomiting. Now, let's get to the pharmacological approach. Like anything in medicine, there's no one regimen fits all. So there's usually a trial and error that we need to do. I think, though, what we should avoid and what we see oftentimes is that we are so undiscriminate in what we choose that we use 3 or 4 different lines all at the same time without having a good assessment and starting with the first line, the second line, and so on and so forth. It's easy to practice medicine by throwing everything at the same time. Of course, one of those will do something, but it is not really practical for the patients to take so many medication, and second, to develop also side effects to any medication that we are going to use. So no one regimen fits all. We need to tailor that to the patient. Most of the time, we all need multiple agents. It's pretty rare that one agent will be sufficient, oftentimes multiple agents. If you remember the schematic representation for the pathophysiology and the different circuits that were involved, the different zones that were involved, even though this is not, again, an equation, this is not a recipe, but it seems that if we have clinical characteristic that seems to tell us that the nausea and vomiting is coming from medication or from metabolic changes, it seems that neuroleptics and 5-HT antagonists will be the best drug to start with. Maybe they won't do necessarily the whole symptom control, but probably that would be a good start. If you have nausea, vomiting secondary to vertigo, as we mentioned before, antihistaminic, anticholinergic may be the best drug of choice. If we have early satiety, prokinetic drugs, and this is something that you see very, very oftentimes when you introduce the opioids, which is slowing down the gastric content, and the patient has a sense that things are not moving down. So again, a prokinetic drugs would be the one who makes the most sense to start. Be careful, though, with early satiety. That can be also an indication that you have an obstruction, either at the gastric outlet or in the duodenum and the bowel, and so you don't want a prokinetic drug at that point in time. This is why I'm saying that the assessment is so important, because there's contraindication of giving certain drug in certain situation. If you have anxiety, we know very well that the benzodiazepine will probably be your drug of choice. CNS lesion like metastasis to the brain, corticosteroids will be drug of choice, and any advanced illness, advanced disease, when we have all those cytokines and some of those humoral factors that will be in the blood system, the steroid seems to be also a very good antiemetic. The antiemetics, we can give you many formula for that. We can give you many examples, many tables, and for the purpose of time here, I'm just giving you in each category 1 or 2 examples. So I suggest that if you want to pursue that, or you have a larger view of all the antiemetics, you can consult, and we have a good bibliography at the end. But I can already indicate to you that one of the very good reference can be the new textbook in Oxford Palliative Medicine, who just published 2 months ago, and who had very great tables on those topics. So that will be the same case for the constipation. So again, look for those. As a principle, you better use a few drugs that you know very well, know the side effects, know how to use them, than having in your arsenal so many drugs that finally you cannot have a grip on them. So use them and know what they are doing and familiarize yourself with them. So again, here, and you have also the dosing in the different dopamine, neuroleptic, anticholinergic. The cannabis can be very good, dronabinol. I will always remember this elderly woman, 85 years old, advanced disease, and she said, please don't take my dronabinol away. This is just what I need to. So that's fine. There's also, like any other type of drugs, some patients may be responding better to certain drugs than other. Therefore, you need also to be able to move your drug around if you don't have good success with one of them. Antihistaminic and the 5-HT, granisetron or densitron, a lot of those are available right now. Multiple of them. There are new ones. The cost can be an issue for those. They should not be a drug of first choice, except probably for chemotherapy-induced nausea and vomiting. So as you can see, each category of drug has a certain specificity, and this is something that we should be familiar with in order to manage well those symptoms. Let me talk about, open and close parenthesis, about bowel obstruction. And just because it is so distressing of a symptom, that if we can do something for our patient, I'm sure it will be extremely welcome. And it's also a nausea, vomiting is a complication of advanced bowel obstruction. I have two cases that I can mention. I will, maybe for the sake of time, maybe mention just one of them. I had a young man who was a 32 years old man with sarcoma of the abdomen. And of course, the nature of this cancer made it clear at one point that he could not eat anything anymore. The tumor was compressing the whole GI system, and therefore this patient was deprived of eating anything. And he was unfortunately alert, oriented, able to articulate all his sense, and he could not understand that just because the GI tract is blocked, that his life is ending. To him, it was something like, do something, do something. And he was imploring us till the end. He could not believe that he will die because he cannot eat, and that was the major problem. So yes, bowel obstruction can be extremely disappointing because we have a sense that we should be able to do something, including some surgery at one point in time to take off the tumor away and allow us to eat. So management, there's multiple options, and the options, what is the most important thing in bowel obstruction, is to understand what is the goal. Is my goal to really achieve this? Is patient also not only the goal, but also where we are at in the curve of the illness trajectory? Is this patient dying and that's a late phenomenon? Or is this patient ambulatory, like this gentleman who I presented was still ambulatory, talking, walking, and doing all those activities? So that's a different story than having a patient who is really end of life, because then you may consider surgery, hydration, NG tube, and or simply you may have to satisfy yourself by symptom control because patient is not amenable to any of the other treatment. What is sure that when you have a bowel obstruction, one of the first things that you have to do, you have to be clever enough to suspect it. And this is why when a patient is having nausea and vomiting, the first question you have to ask is that, is it the beginning of a bowel obstruction? Does he have bowel movement, or also that is not there? And so if patients are nausea, vomiting, no bowel movement for a certain time, you have to be careful with what you are going to use. We don't want to stimulate the gut at that point in time, obviously. Will not make sense, will just increase the complication of the symptom. So probably in any case, you will need some pain medication because it can be very useful. Depending if you are the early bowel obstruction or late bowel obstruction, the pain can be dramatic, especially in a crampy type of feeling. So you will probably need some sort of opioid at one point. A lot of people will say don't give opioid because then we are going to paralyze the gut somewhat more, and then patient will become more and more distended. But even though this may be true, you will need, no matter what, some pain medication because it's becoming very painful. So the corticosteroids may be useful at one point in time. We'll come back to that. Anticholinergic, think about that if you have a lot of crumpy feelings. Antiemetic will be necessary if nausea, vomiting accompanying, and octreotide. I'm introducing this because I want to say one word of octreotide. I know that's not the favorite drug of hospice because there's some cost associated with it, but it can be life-saving and is certainly quality of life in many cases. And if we think that giving octreotide to a patient may avoid the patient to be hospitalized or to have a better sense, better advanced disease treatment, I think it's worth the price. So it's an analog of the somatostatin. It can be used, it has 3 different roles, therefore it can be used for multiple things. It can be used in GI bleeding if you have nausea, vomiting associated with GI bleeding, but also it decreases the secretion as well as the motility of the gut, which are the 2 principles involved in causing this nausea and vomiting. Therefore, it will be worth a trial and see if it will help. You will have less vomiting because the secretion will be decreased. You will have less cramps because the motility will be decreased. So therefore, you will have symptom control. Control of pain, therefore, will be indirectly taken care of. In most cases, in most instances, up to more than 50% of the cases, it is well tolerated, and the dosing can vary, can be given. The only problem also, it's ejectable drug. It is not an oral drug. Therefore, you need to have somebody who inject that, but it can be injected subcutaneously. Therefore, it makes it easy to be given. NG2, we all know NG2 can be very cumbersome to the patient, and it's not everybody. Some patients refuse entirely to consider an NG2. So they have many disadvantages, as we know, but they have advantages as well. And it can help to decompress. It can help to have less of feeling of nausea or vomiting, especially. It is associated only when you have vomiting, obviously, not for nausea per se, but for vomiting. And obviously, if you have a low GI obstruction and you are at the point of vomiting stools, I think it's almost a must because this is really unacceptable to be to that point, and therefore it can be useful for a short period of time. It's usually a temporary measure and not a long-term measure. The venting gastrostomy are, and this is why I wanted to introduce bowel obstruction, because there are a few things that are not necessarily entirely new, but somewhat more in use than ever before. And the venting gastrostomy is extremely an interesting phenomenon, especially has been shown if you introduce that early on, and not when you are in so advanced bowel obstruction that patient become a non-candidate for any procedure because he's too sick at that time. But try to be preventive. When you see that, especially with certain cancer, like ovarian cancer, like colon cancer, when this can be a problem, and at the first sign when we see that there's a mass that will compress and eventually you will become in bowel obstruction, think about venting gastrostomy. It's a safe technique. It gives great results to the majority of patients, and again, patients can go on for months. Obviously, this is not something that we are going to perform in terminal illness, but probably months before, when the prognostic is in a matter of months. So goals of care need really to be considered here. We had multiple patients in which we did that, and their quality of life was so much improved that was really greatest thing we can provide to those patients. There is something newer even than that, although already in practice for many years. As you know, we can stent almost everything nowadays, not only the heart, but also the gut. And there's many places in the gut where we can put a stent. There's the upper gut and also the lower gut that we can use. So it's interesting to consider that. Again, it's not for every patient. It's for a patient that has a certain time to live on. And it's a great technique. The mortality in this review was, I took this review from the Oxford textbook of palliative medicine under the bowel obstruction chapter, and the author was reviewing multiple series, in this case 3 series, and the clinical success is so great with a mortality of 0%. And the complications so limited. The major complication is really reobstruction. So when it comes, we can sometimes do the procedure again or not, depending if the patient, but that is not something major. So that is to say, this is something that's working pretty well if you have the correct patients. I mean, it's not for everybody, obviously. So it's also good for patients who have lower GI obstruction. And it has been shown that the patency can be up to many, many months. The overall complications were a little bit more so than the upper GI, but still acceptable. And so this is something to consider. I will always remember this young woman we had. She was in her 30s, early 30s, ovarian cancer, and she was having a big mass compressing the gut at the exit, and she was on hospice and said, well, shall we consider that? And the results are so good that we said yes, even though on hospice, I think for quality of life purposes, we probably send this patient to the surgeon and see if it's a possibility to be done. And she survived multiple months after that, was able to eat and evacuate pretty well. Of course, this is not indicated for rectal tumor, but for a higher tumor than that. In case of doubt, because we are not necessarily a surgeon, we need a consultation with surgery or with GI, depending who is doing those stenting. And that's really something that we can help patients with. Hydration, as we mentioned before, can be good because patients, it is so catastrophic at times because they have a sense that they are dying by starvation, which is the case in a way because they are not going to be able to put anything, any nutrients. And so having IV fluids can be useful just to give them a sense of psychological sense that something is done, even though we know that it is not going to maintain the patient for a long time because there's not much we can give through those IV line. Parenteral feeding is not really indicated because when this happens, patient is already in advanced cancer. Therefore, putting TPN or PPN will be again a temporary benefit that can be good if you have a goal to achieve, like maybe a wedding, a birth, something that's really a major thing that we would like to achieve and give a little bit more time for the patient. Can be tried, but eventually it will be very limited in scope because we can not eventually increase the survival so much with those techniques. Keep in mind also that in patients with bowel obstruction, if we give too much fluid, because they have a tendency of third spacing, you will increase the vomiting. Of course, the more fluid you will give, the more vomiting you will get. So it should be in a balanced setting more than just in the quantity. Surgery can be indicated. There is some surgery. Usually when you are under hospice or advanced palliative care, very cases will be candidate for surgery because the surgical mortality, morbidity is extremely high. We need good candidates for that, and usually they are not. Most of them have ascites already. They have low albumin. They have carcinomatosis. They have metastatic disease. They are on their hospice, so therefore they are not candidate for surgery. But consider that if the patient is not, and especially if there is some adherence, who is the cause of the bowel obstruction. Lysis is not a big thing to do, and if the candidate is having PPS score that's justifying that, certainly above an ECOG of 2, below an ECOG of 2, that can be an indication at that point in time. And let's talk about constipation. We all know about constipation. Either we have a friend, a family friend, ourselves have to deal with this symptoms that can give you a lot of hard time eventually for patient, and especially a lot of impact on quality of life. So keep in mind that a definition seems a little bit weird of giving a definition of constipation, but I wanted to illustrate by that it's not everybody who has the same bowel habitus. So some patients will go once a week and they always have done that, therefore they are not going to be constipated if they go every 7 or 8 days. So be careful with that. You have to put that into the context of the patient. You have also to be understanding that some of our patients in advanced disease, because they eat less and because they have a lot of risk factor, it's almost normal to be constipation to a point. So again, there's two aspects to measure to the constipation. There will be the measurable symptoms and also the patient's perception. If the patient have a lot of symptoms like bloating, distress, you really need to be much more interventionist than it is not really measured, and that is normal habitus to go only on every 3rd day and so on and so forth. So put that into context. Again, prevalence, we are starting to have much more information about other chronic illnesses, although we know that cancer patients is quite frequent, especially GI and certain symptoms, certain cancer. But it is prevalent as much as 50% in most of palliative care patients, no matter the diseases. You just have to look. Now we have enough data for other diseases, and it's frequent. Why it's frequent? Because in advanced illness, no matter what's the cause of the illness, patients don't eat so well. They are lying in bed, less activities, less hydration, and so on and so forth, which put the patients at risk for constipation. Constipation, we give more or less attention. It's not a noble symptom like pain. It's something second class, I would say, of symptom, if I can use that term. But we have to pay attention. Why? Because we are starting to discover that, first of all, there can be serious adverse effects with constipation, effects that we can hardly fix at one point in time if we let that go too far. It is also a major impact on nursing time. Nurses spend so much time with the bowel, having to give enema or laxative, and all that goes around the evacuation, that it is quite costly. They could use their time, if we would have been able to prevent that, of doing something else, of talking to the patient, of controlling some other symptoms, and not having to deal with that. So constipation etiology, it's again, if you want to treat well, we need to know what we are dealing with. There's the diet that can cause. If you don't eat, obviously you are going to get constipated at one point, or if you don't or if you don't eat the proper food. If you are dehydrated, if you don't drink, the same thing. Why? Because the gut needs fluid for evacuation. If you are inactive, if you don't move, again, advanced age, structural lesion of any type, either from the gut, including hemorrhoids, including fissure. So we need to look for those things, because if we want to control the constipation instead of throwing laxative, we need to know what we are dealing with. Concurrent disease, we all know that electrolyte imbalance, hypokalemia, hypercalcemia, can increase the constipation. Endocrine dysfunction, hypothyroidism, diabetes also, GI disease, diverticular disease, fissures, stenosis, hemorrhoids, all of those can contribute to constipation. Drug-related, and this is something that we forget all the time. We put our patients on diuretics, on anticholinergic to decrease the secretion, and maybe also on iron. So, and then opioids, of course, patients for pain, and then we have to treat severe constipation. Just an hour before we get to this webinar, a nurse called me, patient's advanced disease, advanced dementia. He has anemia, but he's really on his latest weeks. And he said he's receiving iron for iron deficiency anemia. Do you think I can stop that? Yes, of course. It creates more inconvenience than it gave benefit at this point in time. There's no point that we are going to correct this deficiency anemia at this point in time. So therefore, why don't we get also rid of this medication? Pathophysiology, again, if we understand what's involved into the constipation, we will easily understand why we use certain medication afterwards. There's two things involved in the process of the pathophysiology of a constipation. And one is really the motility part, the movement of the gut. And the second thing is the fluid and electrolytic balance. We need both. If there's a problem with one or the other, or both, obviously, we will be in trouble. So the motility is under the control of the mesenteric plexus. And if this is touched either by tumor, like it can be, example, multiple myeloma, and so therefore the gut decreases motility, so nothing is moving, so everything gets packed up. So we will need probably something to play a role on the motility. We need also that the neurotransmitter like acetylcholine and vasoactive intestinal peptide are involved in that. That's interesting to know, because when we are going to find a medication, well, we will have to deal with medication playing a role on those transmitters. Again, fluid is involved in the constipation phenomenon. You know that we produce about 7 liters of secretions a day, from saliva to gastric juice to other juices that are produced by the intestine, and that's very important. And also, of course, with the intake that we have from the outside. So we need that water to also play a role in the in constipation. So in the assessment, when we are going to have a patient who is complaining of constipation, and it is so frequent, we'll have to look at different things. The diet, the general things, the bowel habit, if it's usual or unusual for the patient, physical, social impediments. This is something that we forget oftentimes. Just being hospitalized, just being in another environment can create some constipation. Just pain, think about that also. Patient is so much pain that just going to the toilet can cause so much distress that it will simply not go. So treatment, commode, and not so much anti-laxative drugs. Symptoms, important symptoms, because as we mentioned before, if the constipation is that bad that we're almost at the level of a bowel obstruction, we don't want to use certain medication. And so we absolutely need to rule out the bowel obstruction. And in order to do that, we need to look at the symptoms, we need to look at the signs also, and do an exam of our patients. The nurse will call you from home and say, this patient has severe nausea and vomiting, I don't know what to do. Well, you have to ask the nurse, use your stethoscope, examine the abdomen. Is there bowel sound, no bowel sounds? How long does that been, so and so forth? Look in the rectum, is there stool, no stools? All that will be very important because it will guide us through the right proper medication. Look at bloating, tenesmus, diarrhea also, and all of those symptoms will be indicative of where we are in the evolution of the constipation, which the later stage will be impaction with nausea and vomiting. We will never say it enough, and I still remember my first course when we were using opioid in palliative care and say, well, when you prescribe opioid, always prescribe probably an antiemetic on a PRN basis and also a laxative. And most patients will need a laxative. So prevention is really the goal to start. It's easier to prevent than to treat. General approach that we can do, like in any management of any symptoms, is always kind of a general approach, and then there is kind of a pharmacological approach. General approach sometimes can solve a lot of problems, but not so much so in advanced population seen in the hospice. Increased fiber, oftentimes it is not possible. Increased hydration, it's always good. Hydration is better than eating. This is what would sustain you the most, but sometimes it's not possible. Activity, again, not always possible in advanced disease. Treat medical factors, we mentioned that. Treat the hypercalcemia, of course, all that will depend on the goals. Favorable environment, please, if you have a patient who cannot share a bathroom, bring a commode, do something to make him more at ease, a proper environment. And anticipate constipation, obviously prophylactic laxative. General principle, again, before throwing medication. And as you can see, the first reflex when you have constipation is not, well, what should I do? What medication? It's never that in any symptoms anyway. And I hope that we make it clear through those different webinars for various symptoms that you need to have some clinical thinking before getting to the pharmacological thinking. So exclude bowel obstruction, we mentioned that, and I hope it is now that we will keep that in mind, exclude that. Know the mode of action of laxative, and we'll come back into that. It is not one laxative fits all neither. It's not, they are not all the same. They have all their own characteristic, and depending what we are dealing with, we'll use this instead of that. Discuss the approach with the patient. Oftentimes we prescribe as physician, as attending, or as nurse practitioner, whoever prescribe, or to give an enema to this patient, or let's use this type of suppository. The nurse come at bedside and patient absolutely freak out and doesn't want to. So we should discuss that with them. Some patients will refuse the rectal route for whatever reason it is, and so we have to use and do something else. Adjust the dose and the dosing to optimal effect. There's no reason to give a laxative 3 times a day. 2 times BID, it's enough. So again, this is a principle in palliative care. Minimize the number of pills that you take all the time. Combine the agent most of the time. It's a bit like the nausea. You will need to combine the agent. Consider alternative if it does not work after you maximize the dose. And don't throw different type of laxative. We often see patients with 4 different type of laxative. Probably there's no reason for that. 2, most likely it's okay, but when we get to 4 laxative, what are we doing here? Probably the evaluation was not satisfactory, tailored to the patient's cognition and symptoms. Specific situation. If you have an empty rectum, forget about putting a suppository because you will get nowhere. The suppository will come, will melt, and that's it, you will not get any results. So that is to say you have to examine the rectum when you treat constipation. High enemas is probably the only thing that will give you some good results, and most likely with oil. Large fecal mass, well, there's no way, if you have an impaction, that just oral laxative will do something, and even suppository. You will need a digital disimpaction manipulation, probably followed by oil enema, and repeat with high enema for a few days. So depending how severe is the impaction. If you have hemorrhoids, again, patients won't go, even though you give all kind of laxative, it will just fight you. You need a stool softener, obviously, but you will need probably also an analgesic suppository. And if you have a mass, and we see that in various types of cancer, of course, rectal cancer, but sometimes as a metastasis. And please consult surgery to see if there's any stenting, or if not, radiation therapy if you have a fungating mass that really obstruct and give a lot of symptoms to the patient. There's something that can be done. Sometimes it will be a diverting colostomy, but never say, well, nothing I can do. There's always something that can be done. Sometimes we need specialists to help us to solve the case. Larkin, in her paper about laxative, summarized a little bit to give us some kind of recipe for the use of laxative. Again, I don't like necessarily recipe because we tend not to think too much when we use recipe. We just apply them without, thinking, is that really the situation that I have in mind here? But you won't not go wrong, most likely, if for normal constipation without complication, using a stimulant with a combination of a softener. A stool softener like the docusate can be used at any time, no matter what, because it's just softened by definition, does not stimulate, so therefore there's no contraindication, and so you can use that. If it's good, you continue with that. We don't need 4 or 5 types of laxative. 2 is enough. If not, it's not working. When you max out the dose, you may want to add a third line. The third line will be, it can be one of those more harsh, like go lightly, things of that. Lactulose can be also, but then again, those can be contraindication if the patient is really dehydrated. And the last that you are going to use is really the opioid antagonist. So let's see how this is working. Again, you can find multiple charts. I wanted to give you a simplified one. It's divided in 2 parts. The first part is really the mechanism of action. If you know what's the cause of that, if you know, so then you know what kind of laxative, and you just have to pick one in that category of. So bulk laxative, we know that psyllium will be one of that. We said that it's not really well indicated in our patients because they don't have enough water to mix with that fiber, and then therefore it probably will not help. You have the osmotic laxative. Keep in mind that you have to be hydrated for that. Lactulose is in that category. Polyethylene glycol is in that category. Be careful. I still remember a case that we did have patients in our 50s with multiple myeloma, already had a slow gut. The plexus was involved, and therefore she was already having a very low motility. Patient, we give lactulose, and in a matter of 48 hours, she became so bloated that she could not breathe. She has to go to the medical ICU to be decompressed and having a little bit of BiPAP to push somewhat of the oxygen because she was totally not breathing at all. And that was good. So lactulose, very good. Be careful though; it can increase the bloating increasingly. The stool softeners always have a stool softener on board. I think they are inoffensive. The stimulant, yes and no. Don't stimulate the gut. That is in obstruction. And the methyl naltrexone, which is only one of those example in the opioid antagonist. So again, I have another example here of different type of laxative with some names and some dosing on that with a mechanism of action. So when you use one of them, you really need to know the mechanism of action. No need to take 2 of the same categories, example. That is not necessary. Try to vary your categories in which you are going to use them. So again, mineral oil, it's not one of the best, you know, that has been associated with aspiration, pneumonia, and really prevent absorption of food. So really, it's mainly reserved for enema, oil enema. In the category of the opioid antagonist, you have three now. It's a category that's developing rapidly over the last 7-8 years. And now we have the oral form that's called Nausea, and this form is really effective, again, but it has been recommended so far. It's brand new on the market for about less than a year for non-cancer opioid constipation, long-term chronic pain patients who are on opioids. So we still need to experiment with those. Cost is an issue for all of those, but it can be extremely effective when the other laxative did not go. Again, all contraindicated in bowel obstruction. So I'd like to conclude by a very sad case, and that exemplify to me the necessity of examining our patients. We have a patient, a gentleman who is 70-year-old man. He has a colon cancer, metastatic to the liver, was at home on hospice. And the poor man developed progressively constipation many days, and out of sudden complained of severe abdominal pain. So everybody was putting everything in the context of constipation, give more drugs, and give more pain medication and so on. And after 24 hours of that, he needed to come to the emergency room because none of that was really useful. And he was found to have a perforated bowel. And that was very sad because it was, again, there was some time frame before we discovered that. And he suffered also a lot of pain because of that. So again, maybe if we would have examined the patient earlier, instead of saying, well, it's just pure constipation, let's do something, we may have a different disease. He almost died from that. He did recuperate, matter of fact, and was able to eventually go home, but that was really a terrible ordeal for this patient. So I'm stopping here. We are over time, we know that. I think we are going to take some questions here, and for the one of you who could not listen to the whole, of course you will receive all the slides and the bibliography. Let me indicate again to you, repeat that, and again, I'm not promoting this book, but the Oxford textbook of palliative medicine, in at least in all those symptoms related to constipation, nausea, bowel obstruction, is very well done. It's a source of incomparable, really, information, and I think that you will certainly enjoy that. It's well done. So let me grab a question here. What are your levels of concern? Antiemetics. Please talk about interval of antiemetics. The level of antiemetics usually we see, and I'm talking mainly colase and Sinucat, which are, or colase, docusate, or a stimulant. Those are the most commonly used. And I oftentimes see 1 tablet 3 times a day. I don't think there's any rationale to do that. 2 tablets, BID will be doing probably exactly the same thing. And the patient will not have to take 3 times a day. You just, you know, imagine yourself having to take medication many times a day. It just comes to a point that it becomes too often, and then you will like to do, and if the result is the same, it will be great. The same with the steroids. If you use the steroid for nausea or vomiting, BID is sufficient. You don't need QID. It's a long-acting medication, and this is what I'm saying by this is what I mean by saying know your medication, in a sense that if you know what they are doing, the longer action, so you will know how to use them appropriately as well. Remind practitioners to review all imaging available for any patients. Constipation often not commented by radiology. No, it is true. This is why there's no one test fits all. The question is that oftentimes the radiologist will not comment on constipation, and having maybe an X-ray is not necessarily, it's not something that we need to do at all time. I think clinically sensitive, a good clinician will be able to do that before even resorting to an X-ray, by having palpation of the abdomen, listening to the bowel sounds. By the clinical, so no evacuation for 4 days, obviously something is going on, and so on and so forth. So I think a good clinical will be probably your best bet, and that is correct that they do not. But if you are in doubt and by your clinical evaluation you could not go to there, ask them to comment on that. As you know, radiologists have their own way of doing things and commenting of what they like to comment on. But if you are looking for specific things, if you ask them, they will pay more attention to that. And a gut that is full of stool is obvious to even just a plain KUB, and you will be able to see that. A patient is using both lactulose in a PEG. A patient has rectal cancer. Any comments or suggestions? Patients with rectal cancer, you have to be careful, because you know that with time they may develop obstruction, and they will develop the sign of obstruction, like we mentioned earlier, even though we did not go into details of bowel obstruction, what can give you as far as signs and symptoms, but you know that nausea, vomiting will be, no evacuation of stools, and bloating of the abdomen, and a silent abdomen. So if you have those signs, if you have a rectal cancer, it's not because you give that through a PEG that you will have a different. No matter which way you are giving the medication, it is the absorption that will make a difference. So via PEG, it's like orally. So it will make the same thing. And if you have close to an obstruction, you don't want to stimulate too much the gut. So you may need at that point in time, depending when you are in your goals and depending of your evaluation with prognostic of the patient, you may want to ask a surgeon, or as I mentioned before, a radio-oncologist, who said, can we shrink the mass with some radiotherapy? Sometimes it's good enough to have some relief or some opening in the rectal area, or put a stent depending on where the tumor is. So again, we need some expert to guide us if it's indicated in the case of the patient. Let me, when we ask about last BM, the family always answered, but they haven't been eating. Correct, and I'm glad you mentioned that, and this is something I should have probably said. I'm hearing that all the time when we make rounds, and that is not true. It is obviously true that if you don't eat if you don't eat much, you will have less output. Input and output will counterbalance. The more you eat, the more you should have output. This is why if a patient is not eating too much, we are not concerned if he doesn't go and have a bowel movement every day. Every 2 days, 3 days may be sufficient enough. So I think that we have to explain that, and as I mentioned before, don't forget that the gut produce some also all kind of secretions, all kind of residual stuff that eventually, it's not just food what you do see in the stool. So therefore, even though you don't eat, you still produce some material to evacuate. Less often, yes, but that's the only difference. You are still producing. Are you suggesting a venting gastrostomy tube as prophylaxis in certain cancer? I would not go as far as going preventing. And then again, you may want to discuss with the team in your hospital we are dealing with. But when we have a patient, and we have a similar case, I remember very well, patient was quite alert, oriented, still have some quality of life, was walking, and developed a first bowel obstruction. Was not a total bowel obstruction, but enough to let us know that eventually she will go back in more obstruction. It was not a total one, and so we decided at that point in time to ask a consultation to surgery and see if it will not be the time and not to wait that she's so sick, then they are too sick to put one. So I would not say, no, wait till you have probably a bowel obstruction, but don't wait till this bowel obstruction is so bad, it's total, and then we need much more aggressive surgery to relieve the patient. So let's be proactive, and in case of doubt, you may want to ask your consultant and see when will be the appropriate timing. But wait till you have some sort of a bowel obstruction. I will stop here. As you can see, we can go on, and this is a topic that we are all familiar with because we see that on a regular basis. But again, I strongly suggest that you consult those books mentioned in Bibliography to complete your knowledge on those two topics. So just a reminder while we are leaving here that the next presentation will be by Dr. Alessandra Estrada on June the 11th, and she is going to address the topic of understanding existential distress and managing and meaning-oriented therapies in patients with advanced illness. That promised to be quite interesting. Please do not forget neither to give us your evaluation and suggestion for further comments. That's always interesting to hear from you.